The disparities relate to the differences between clinical trials and real world. So in clinical trials, we've cherry-picked really healthy patients. The treatment team is geared to treat till progression. The patients are also more likely to be going till progression on therapy. And there's more radiologic screening, which might shorten the duration of treatment. Conversely, patients may come off earlier because of biochemical progression due to rigorous testing. So when we go to the real world, we have patient factors where you may have patients that are older, have a lot of comorbidities that would not have been eligible for the study. And then patients may not get treated till progression because of either patient fatigue or physician or nursing fatigue in terms of continuing till progression. And then, of course, if physicians aren't checking rigorous M spikes, they may keep them on longer. They may keep them on even if patients aren't having even if they have biochemical progression, but if they don't have clinical symptoms, they may continue longer than a study would allow them to. But in general, what we found is that treatment durations tend to be shorter in real world than clinical trials, probably because of the patient comorbidities and the perhaps treatment team's intention to treat to progression. First of all, there's no clear dominant treatment pattern in myeloma, neither by region, age, newly diagnosed or relapsed. I think that's one of the important findings from this is there's a lot of heterogeneity in treatment across the world. But what we do see in the US, the most commonly used induction regimen is VRD or RVD, which is not used in Europe. We see more CyBorD, VTD in Europe, so that's a big regional difference. Second thing is that triplets tend to be used more in newly diagnosed younger patients, transplant eligible. We see more doublet therapies in older patients, and so those are some of the differences we see.